Welcome and thank you for joining us live today on YouTube. My name is Kevin Kim, and I am the Operational Analyst at the World Bank of Korea office, and it is an honor to be your MC today. The task team for this project includes Vikram Rajan from the HMPGP, who is co-leading this project with me, and team members Caitlin Jizan Yu, Aram Han, and Akasua Dakwa. Now, before we get started, I would like to mention that the chat function is active in the YouTube live stream. Please send in any questions and comments about the presentations and the panel discussions, and we'll get back to you live if time permits, or through email. Through the generous support from the Ministry of Economy and Finance of the Republic of Korea, this webinar series has been designed to gather knowledge and share experience of the East Asia Pacific region in responding to the COVID-19 pandemic. Our objectives for this webinar series is to promote knowledge generation and exchange adaptation for international best practices in preparing for and responding to subsequent phases of COVID-19 and any other future pandemics. Our first webinar held in April took a deep dive on Mongolia and Korea's response and preparedness efforts. We have put a link to our project website in the YouTube chat box where you can find the recordings for those who missed it. Now for today's event, we'll be focusing on the experience of Malaysia and Vietnam, followed by a panel discussion by experts who will reflect on the lessons learned and how we can assist our client countries on effective methods to prepare and respond to future pandemics. Our final webinar on Fiji and a cross-country analysis of the 5 case countries will be held in the fall, so please stay tuned for more information. I would now like to invite David Wilson, who is the World Bank's Program Director of the Health, Nutrition, and Population Global Practice, to deliver his opening remarks. David, the mic is yours.
Thank you, and hi everyone. It's a pleasure to welcome experts from Malaysia and Vietnam to today's important peer learning event. And we particularly wish to thank the Republic of Korea for their far-sighted and generous support for this effort to harvest the lessons of COVID and to strengthen future preparedness. As we exit COVID, thanks to the outstanding vaccines we have developed and produced at such speed, there are so many important questions to consider: programmatic, scientific, and production questions. Programmatic questions include how best to reach the elderly and comorbid with at least 3 doses, overcome hesitancy, select the incentives that work best, especially among the elderly. Scientific questions abound, and examples include homologous versus heterologous, or mixed and matched vaccines, and the optimal order, number, and mix of vaccines, including the inclusion of new vaccine candidates into our regimens, optimal dosing and boosting regimens, and the potential inclusion of Omicron-specific or bivalent ancestral and Omicron-specific booster vaccines. Production in questions include the optimal balance of global, regional, and national production, the challenges of production in a vastly oversupplied market swamped by donations, and the best vaccine platforms to invest in. We are all understandably concerned about vaccine equity in a world with such unequal access to vaccines, and yet we are confronted with a huge global collapse in demand. The world has hundreds of millions of vaccines, many of them mRNA, which we cannot give away, even free, and hundreds of millions of doses will expire or be destroyed. And faced with this collapse in demand, perhaps our greatest priority is to ensure that as many people over 60 as possible get at least 3 doses of almost any combination of approved vaccines. Hong Kong is a grim reminder of what can happen when vaccination rates among the elderly are lower than among the young. And finally, today's topic is poised between the increasing certainties of COVID, a known respiratory pathogen we readily develop immunity to, and excellent, safe vaccines on the one hand, to a panoply of future potential pathogens for which these certainties may not apply. And together, we must harvest the lessons of COVID, without devoting future health security preparations to prosecuting the last war anew. Future challenges will almost certainly be very different to COVID. And with these initial remarks, let's turn to our outstanding group of speakers and specialists tonight from Malaysia, Vietnam, and our virtual hosts in Korea. Thank you.
Thank you, David. Now, without further ado, I would like to welcome our first presenter. Dr. Tilaka Chinaya is the Deputy Director for the Disease Control Division, Preparedness, Surveillance, and Response Section at the Ministry of Health, Malaysia. Dr. Chinaya was involved in many outbreak investigations and was at ground zero when Malaysia detected its first case of MERS. With her operational health background, she is an expert in investigating hospital-acquired infections and outbreaks for the Ministry of Health, Malaysia. Dr. Chinaya, thank you for joining us. The mic is yours.
Thank you, Mr. Chair, for the kind introduction. I hope you can see my slide and hear me well.
Yes, we can. Thank you.
Okay. Good day to everyone. I would like to share today on COVID-19 preparedness and response, especially from Malaysia point of view. I am a public health consultant for MOH Malaysia. So this is going to be the outline of my sharing today, where I'm going to touch a bit on prevention, preparedness, response and recovery. And if you have seen in 2019, there was a survey was done regarding the countries best and worst prepared for epidemic. The good news is Malaysia is in between, that is more prepared. So with that background, let me tell you a bit on the prevention activity that have been done in Malaysia. We always believe investment during the peaceful time is the best. So what we have done is we have adopted Asia-Pacific strategy from emerging disease, which is developed by WHO at the Western Pacific region, and we have converted into our Malaysian strategic work plan, and it is a 5-year plan, and which is in the latest is a work plan 2, which will ended last year, and we are working on the next new framework. And these are the other activities of preparedness in view of preventing the emergencies or the outbreaks. So we had a various simulation exercise conducted nationally, internationally, and also with collaboration with WHO. Especially every year we do IHR crystal exercise with them. And also a real-time event also have taught us a lot of experience, given us a lot of experience and also a lesson learned from there. I've just listed out few here, like rabies and polio was already eliminated from Malaysia, but we had an outbreak in 2017 for human rabies and also polio in 2019 where we are dealing with it. And also the other great experience was an illegal dumping of toxic waste involving 6,000 students and also a population around that area. This is a very large chemical event in Malaysia, so we have had a hands-on experience in managing this. And also with that we have a program called Epidemic Intelligence Program, which is equal to FETP or EIS in US, where we have field epidemiology training. We send our staff overseas, like a few of us have supported the deployment in West Africa for Ebola outbreak, and also we have regular attachment at WHO Western Pacific Regional Office to enhance our skills. And after doing all that, we have to test where we are. Are we doing enough? So for that, we have embarked on the joint external evaluation in 2019, where Malaysia was given as high level of achievement in fulfilling the international health regulation requirement. If you see here, this the down score, we have scored more than 80 for all the core capacities, whereas only one capacity here, which is around 60, that is for biosafety and biosecurity, where we are already working on it to strengthen that part. And also, if you all know, let us go to the event now. And mid-December, we know Wuhan, China reported a cluster of pneumonia cases. Since then, we started working on this response level under the local epidemic curve. If you look here, we have alert, containment and mitigation phase, where we start responding to any outbreaks in the world. So what Malaysia have done is we have converted this into our disease outbreak response matrix, or we call it DOM matrix, where we converted all these phases into different actions that need to be done by the Ministry of Health and also other related agencies. But at the most, we have come only to a hybrid kind of situation where we do late containment and a mitigation phase at once. So let me take you all through the preparedness phase alert activities. That means before we even had a case in Malaysia, when China reported the cases, we already started preparing in Malaysia. Like what we have done is we have alerted all our healthcare facilities and also international point of entry that started as early as 5th January, and also we shared the WHO guideline, and also we came out with our interim guideline for our own use based on our capacities in Malaysia. And also we had promotional activities at the point of entry where we created awareness to all the frontliners, international travelers and also general public about the disease. And also we started screening at the point of entry using thermal scanner, and also we strengthened our surveillance activities at the point of entry. We made flight announcement, aircraft health declaration form was used, patient self-declaration if they have symptoms, and temperature screening. And also we worked with the immigration department to refer all those cases with symptoms to our nearby health center. And also we distributed health alert card and home assessment tool for them to seek treatment if they have any symptoms of pneumonia, or in the beginning it was called nCoV. So this and other thing also, what we did was we did collaboration with various multiple agencies, because we know later we have to work with them if the disease have been introduced into Malaysia. We had collaborative effect with the director of immigration, asking them help if at all we needed at the point of entry in the case of importation. And also we engaged all the international school, especially with the Chinese student, so that we have prepared them to face if they have any cases or outbreaks in their institution. And also we engaged with the travel association, all the travel agency, even whoever catering, especially for China. And then we have also given travel health advisory to them, and also various Ministry of Tourism, because we know we never shut down our entry point at that time, so we have to cater for all these so that they are well prepared and they know where to seek information from. And also our own health facilities, we have prepared the health facilities, and like we have informed the signs and symptoms of this pneumonia at that time. And also we developed a triage counter for fever, and then we screen them, and we don't want them to come into the health facility and spread the disease, so we had a triage facility over there. And at the same time, so on 22nd January, about 3 weeks after China reported, we started creating awareness among all our healthcare workers, including we gave hands-on training on PPE and also how to manage spillage and also disinfection. If you see, our last test was on the 23rd of January 2020. And then what happened? We received our first case of confirmed COVID case on the 25th January, which was just 2 days after our training was over. That was case imported from Singapore. Singapore reported their first case on the 23rd January, and it crossed border land crossing and came into the state of Johor in southern part of Malaysia. And it was communicated to us by IHR communication from Singapore. And then if you see from there, this is the epic curve overall. If you see, we had the first wave of imported cases of only 22 cases. And then later, we had a second wave which started on the 27th February, where there was a big international religious group mass gathering, where about 16,000 people gathered in the capital, with around 2,000 from foreign countries, and that triggered another second wave for us. And then the third wave, if you look here, that also was contributed due to mass gathering which occurred during a state election in the eastern part of Malaysia, and then that was brought into the West Malaysia, and we had another break. Following that, you can see we had a Delta peak and also Omicron peak. In the beginning, we were managing single-digit cases, then went to around 500 cases in the religious group, and then later it came to 5,000. And at the Delta and Omicron, you can see we were been managing 24,000 to 33,000 cases per day. And then based on that, we knew we have to flatten the curve as early as possible. So we came out with the National Strategic Plan for Pandemic, where we had 6 pillars. If you say our aim was to stop the transmission, to reduce the mortality, to increase the lab capacity for surveillance and diagnostic, and introduce the vaccine and increase the coverage, and also to give mental health and also social support, and finally engage the community with the empowerment and also their contribution. This was aided by multi-sectoral coordination, because as you know, our national disaster agency was activated, and we were coordinating at the central level with various ministries in Malaysia to work with, because this pandemic wouldn't have been possible to be controlled if not help from all these respected ministry. With that, we had also legislation, ordinance, policies, and also enforcement, along with all the other resources. Especially, I would like to highlight here about digitalization. We introduced very early digitalization into our system, because we know our human resources are very scarce, so we have to face that. So very early we introduced. I will take you all through that. And also, these are the main 2 act and ordinance that we have introduced. I mean, this was there in the beginning, prevention and control of infectious disease since 1988, but we have to amend that and revise it to cater for the current pandemic, because we have to address the movement control order that we have imposed, and also the public health measures, which is very important in controlling the disease. And also we use the other employees minimum standard of housing accommodation, because we have been seeing clusters happening in workplace, so we have to control that. So we have used even this act. And also there was a lot of rumors were going on, and a fake news being shared. So for that, there was a ordinance, an emergency ordinance was introduced in 2021, where we can order them to remove the publication of the fake news, and can be given imprisonment or a fine for that. And these are the various approaches that we have done. I'm not going to go through everything, but it's only mainly on public health intervention, diagnostic testing, movement control order, evidence-based, approach-based, and also all the guidelines to guide them, and also risk communication and isolation and treatment. And if you look here, we have gone through 4 phases of MCOs, and the time frames are here. And if you look at the cases have been reported, the cases started coming down the red dot line here only after the 3rd MCO that we have started. So the cases started dropping in. And these are the various activities that we have carried out during the pandemic. And here, after the MCOs, we went into a recovery phase, where our national recovery plan included a 4 phase. And what we have done, we have slowly tried to relax the all those restricted measures that we applied earlier. The MCOs, we started relaxing it first to essential, and then we went towards most needed, and then it is slowly we have improvised to the phase 4. And then the other thing is introduction of our national COVID-19 immunization program, which was introduced on the 24th February. It's about 2 or 3 months later than all the other countries on the western area. However, we had a 4 phase for this, where it started with the frontline vulnerable group, high risk group, and the last one just we have started a few months ago was phase 7, which we started giving vaccination for 5 to 11 years old. And these are the various places that we have provided our vaccination. We had mega vaccination centers at the malls and also at the stadiums, and also we have vaccination centers in the health center and our hospitals. We had drive-through, we had door-to-door approach, we have mobile vans that to provide vaccination, and also our general practitioners and private hospitals were included also into this vaccination program. So we could achieve a very good coverage with all these contribution. And risk communication, it is another essential component that we have been seeing. During peak, we were really receiving about 25,000 calls per day, which we managed in the beginning manually, then we transferred it to a virtual way later part of the pandemic. And at one point of time, we said we have to manage between life and livelihood. We cannot be continuing having MCOs and closure down and most of the economic close. So we came to a conclusion that our borders to be open, our economic supposed to be resumed based on a few facts that if we have seen in the beginning of the April, the daily cases reporters was coming down, and also people admitted in the ward also was coming down, and patients in the ICU was also dropping down, and our death was showing a very good sign. With that, we have seen also our RT value, which is the transmissibility of the infection to all the other people. We have seen it is always below 1, which gave us a confidence to open up our borders and also the economy. On top of that, if you see, all the antivirals were still available, antiviral drugs were available for COVID. We have already started distributing Paxlovid and also Evushil, and also our vaccination coverage. If you look at the total population, we already reached second dose of 83%, and adolescent is about 93% for second dose, and also if you look adult more than 18, it is already 97. But we are, since this 5 to 11, we are still working on it, where it is coming around 40% now for the second dose of vaccine. And then Malaysia entered into a transition phase to endemic. It is not endemic phase yet, but we were in the transitioning phase, where we announced on the 1st April, and we said people have to learn how to live with the virus, and we don't want any more enforcement, we don't want any more government intervention and act, but we said it should be individual responsibility and it should be community solidarity. So with that, we had 7 components to abide to, and also to guide us through this transition phase, where we had standard operating procedure. If you all know, previously we had about 181 guidelines and SOPs. Later we said only a single SOP with 9 guidelines is sufficient in this phase. And also we had a heightened alert system, testing, and also we had a program called Test, Report, Isolate, Inform, Seek. This is through the community to the individual, they have to do this. And also we have digitalization system, mostly automated system in place, and also economic, where we talk about reopening of international borders and also community engagement. All these were continuously supported by the risk communication that were being carried out. If you look here, that's the thing what I mentioned here, 1 SOP. We have only 1 SOP with 9 set of guidelines. These are the 9 set of guidelines which will guide these different activities to be safe during this transition phase. And also this was a lot of relaxation was given on our SOPs. The face mask was optional, but it is compulsory at the indoor, and no more scanning for the QR code at the entrance is required. And all individuals, despite of their vaccination status, are allowed to enter the premises. There was no travel insurance required for foreigners, and also there's no more physical distancing is required, and pre-departure test and also on arrival tests and quarantine was not required for fully vaccinated travelers. And also we have updated our protocol for positive cases, where the positive cases will be isolated for 7 days, but once and the 4th day they can test themselves, and if they are negative, they can be out of the isolation. And also this is the heightened alert system, a matrix that we follow to have alert our own healthcare system, and also to the community to tell them where are we right now, and each level we have the response activity that we are supposed to be doing. If it's in the red, we are supposed to be doing certain activities. So we have this in place for a reference. If you look here, this is how we monitor weekly. This was previously, and this the latest. If you can see, no more red area, we are seeing more of green here. And the other one was the national testing strategy. We have a very good testing strategy in place to guide everyone. This is the outline of the testing strategy for people to refer from all the various ministries to manage. And this is the other practice we have mentioned. We are going to empower the community. Government is not going to look after every individual and tell them what to do, and if they don't do it, punishing them and all that. So we said, we came out with these 3. You have to self-test. If you are symptomatic, symptomatic, and you have to self-report and have to self-isolate yourself at home. And if you deteriorate, please inform us. And also if you need support, especially psychosocial support or mental health support, you can seek through the numbers that we have given. We have advocated this throughout the country. And also the digitalization I mentioned, I will touch on this a bit, because we know since April we have developed and we have 16 modules under this digitalization with 6 different systems which is integrated within. So it's very good for the user, because they have to just key in into one system. It will be integrated, like once if you test yourself and then you report, it will be integrated to the lab, it will be integrated to contact tracing, it will be integrated to home quarantine monitoring, and also vaccination, all those what I've listed here. Everything is integrated into an online digitalized system that they don't need a manpower to go and do a contact tracing. The contact will be monitored through digitally, and also there's CAC which is will be monitoring, and if the signs or symptoms that they are reporting twice daily deteriorate, they will be referred to the nearby health clinic or the hospital. And this economic, when we decided to open up our borders, even before the 1st April, we started testing the ground. Like we had a Langkawi travel bubble where we only a certain islands open for travel, so that we can see how it is how the disease will spread, or what are the things that we need to take note. And then we opened up a vaccinated travel lane with certain countries. We started with Singapore, then extended to other few countries, and also latest is we are allowing people with fully vaccinated status to enter Malaysia without any restriction. Now we are open for all travelers, and the travelers without vaccination, they have to be quarantined for 5 days, and then they need to undergo a test, and if they are negative, they will be released. So that is the stand in Malaysia. So this is the community empowerment. We have My Champions, we have a lot of already existing community society who are working with us in the beginning. So we have engaged back with all of them to give us support, because without their community engagement and support, this pandemic won't come to an end. And I think the way forward for us is, if you look at this, we are doing good. The cases are already coming down. Our death right now, our cases in Malaysia is between 1,000 to 2,000 per day, and also our death is always a single digit, which we are monitoring. And also this is the variant of concern that we are monitoring. If you see here is the yellow one, previously were reporting all on Delta, then it is changed to Omicron. Here if you can see, it's the red in color. But later, now we are monitoring even the subvariant, when we are seeing more of BA2 here in Malaysia right now. But we know recently BA4 and BA5 been introduced in South Africa in January, and this has been giving a lot of a big and troublesome wave in all the other countries like US, UK. They all are facing another surge, and also in our ASEAN region also. So Malaysia, we just reported our first BA5 and BA2 12.1 in June 9th, and as of today we are having 5 BA5 cases, and we have BA2 12.1 is 6 cases we have, but we don't have any BA4 in Malaysia yet, but we are still monitoring, and also we are prepared for the worst to come. So again, the cycle goes back to preparedness. Once we have gone through the preparedness, response, recovery, now we are back again into preparedness levels with knowing our capacities and all those things. So I think with that, I thank you for your attention. Thank you so much for this opportunity.
Thank you very much, Dr. Chinaya. Now I would like to introduce our second presenter from Vietnam. Dr. Pham Quai Thai is the Vice Head of the Infectious Disease Control Department at the National Institute of Hygiene and Epidemiology. His work relates to infectious disease surveillance and response. During the COVID-19 outbreak, he joined the Rapid Response Information Team under the National Steering Committee for COVID-19 Prevention and Control. Dr. Thai, thank you for joining us. The mic is now yours.
Good morning, good afternoon, and good evening. Thank you very much to let me have a chance to present you a case study for Vietnam, how we prepare and how we respond. So let I start by highlighting some of the main outcome in this presentation. The current status, we have the number of cases about more than 10 million cases so far recorded. Actually, it not fully reflects the real situation in the country, but it somewhat like what we see so far, that we have about 500 and 800 patients a day now, but not many of them hospitalized or severe. Very few severe so far recently. And we have a vaccination rate more than 99% for the 2 dose, and the 3rd dose and the 4th dose also increased by time. In Vietnam, COVID-19 really challenged the whole economy as well as the healthcare system. And the government responded quickly and moved decisively with a stringent measure following the identification of the first case, and the government already took various effectiveness measures to prevent it. And what we learned so far is the transparency and the centralized disaster response system had facilitated intergovernmental risk communication and coordination. Our evidence provides a shared lessons from our country of successful COVID-19 prevention and control, as well as recommended the next steps to overcome the impact of this type and pandemic on the economy in Vietnam that could be useful for other nations. So let me start with the current situation of COVID-19 in Vietnam. Somewhat like a Malaysia case study, we are looking for an endemic disease to change to. And until now, we have we get the 12 highest number of infection, but based on population, we are ranking at 104. And how much of the case and the death so far today? We have a very big outbreak during February, March this year because of the Omicron's number 2, I think BA2, BA3. But so far, the number of cases declines sharply, and we have somewhat like 600 cases a day and 1 or 2 cases a day. And to do that, the Vietnamese health system react similar the way Malaysia do. We have the 3 levels: the central healthcare, the provincial, city healthcare, and the grassroots healthcare. And among grassroots healthcare, we have about more than 12,000 of facility that can doing the universal healthcare. But beside that, we have a specialized healthcare that control the severe case. That's the reason why we, at the very beginning of the outbreak, we follow the zero COVID policy. That's why you can see the Vietnam economic contraction in 2020 is somewhat similar to normal. It not much change until the attack of Alpha variants about the second half of the year. And after that, we can see a reduction of GDP. But after that crisis, it returned to normal until the second attack, or we call it the 4th wave of pandemic by Omicron, by Delta. And during the Delta time, from August 2021 until October 2021, we can see a very low or reduction of the economy. But right after that, we have enough vaccine and we cover the population with the vaccine and we gain back. And so far, the economic growth returned to normal. I think it's one of the fastest country that returned the increase of the GDP so far with the world. So the redirection of the epidemic prevention strategy, we moved from the zero COVID until going to the adaptive flexibility and effective control of the COVID-19 with the work of testing, isolation, treatment, and vaccine. So with a high coverage of vaccine, maybe we can reduce the 5K into 2K so far in the future. As you can see in this graph, there is I try to blur the name of the policy, but I mean here the policy change very quick accordingly with the change of the pandemic situation. So far we have about 500 different government guideline documents that have the health system and own other sector to go up with the pandemic. Here is information about the COVID-19 vaccination campaign. In order to prepare, the government tried to find all the way to get a vaccine from outside. We have the vaccine from the procurement, vaccine from donation from other country, and many other diplomacies vaccine strategy. That really helped the Vietnam access to the enough quality of vaccine, and so far we have a total number of 255 million doses from different sources. It is a great number of vaccines so far, and what we have is enough for the whole population. However, the vaccines is not just coming that way. It's not coming gradually, but it's coming like occasionally. It means that we have to adapt with the amount of vaccine coming in the country. So vaccine delivery will also change accordingly. We also have a big campaign like vaccine delivery in the stadium or in school, but at the late stage of the vaccination campaign, we even give the vaccine overnight and deliver at home for the people who have a difficulty to go to the vaccination site. And for COVID-19 vaccination safety, Vietnam has provided vaccination guideline and training for 6 types of COVID-19 vaccine so far. It means Vietnam, I think Vietnam is one of the countries that trying to import any vaccine that WHO's approved. That really have the flexibilities of the use of the vaccine, mix and match, and other things. The vaccine development in Vietnam also ongoing, and we also have some of the local vaccine that used so far. And currently, we already use 224 million doses, and we try to minimize the wastage of this. It means with such a dose of shot given, the wastage of vaccine is very, very low. So here is some information about the vaccination, the different vaccine that have been used in Vietnam, and you can see even the second dose or the third dose or the booster dose we have achieved at the high level. So far for the primary dose, we have more than 99% of coverage. And booster dose, we have somewhat like 74% for the first booster. And the second booster now, we try to get somewhat like 30 or 40%. This is the graph about the different age group and different group that have the vaccine. And if you can see the vaccination in the teenage also at a high level of 97.8%. We can see a great impact of the vaccine when compare the number of severity, the rate of severity, and the case fatality related to COVID-19. And even we have a very high level of laboratory confirmed case in children, in adults, recently when the Omicron spread through. But the number of severe and number of death is minimal. You can see number of death now very close to 0%. Very few cases die a day, or they just because of the very severe comorbidity. But now we face with the challenge when we try to cover most of the population. The remain is very difficult to reach. It's vaccine hesitancy also increased, the mobility of the population, and also data management for the vaccine also have to be improved in the future. We also have a great improve in the treatment solution. So the medication support treatment by Ministry of Health that try to maximum the resources supply of drug, of oxygen, and other resources for the health. And the health insurance fund also really a great source that have controlled the epidemic at the very beginning. However, after when the spread of the virus increased, we also need the aid from other support, the other country and international organization. And at the beginning, as we can see, we focus on the zero COVID strategy. That means we use even the 3 layer of contact tracing. That's why we catch most of the case from the very beginning, and that's why we keep the 2000 and early 2020 and 2021 safe before the attack of the Delta. And here is some example how we change the strategy. We start with the lockdown of the local lockdown and mass lockdown from 2020. We move it into the local lockdown, smaller lockdown in 2021, and later on the latest or the last lockdown applied for Ho Chi Minh City by July 2021 until October 2021. And then after that, when we have enough coverage of the vaccine, we start to open. And from October 2021, the lockdown is not mentioned in any document. So in order to get that, besides with the vaccine, we can see that the primary care and the hospital response is also the great improved during the pandemic. We can see the 4 on spot. We can see the deploy of the care and treatment in infected people at home, and also the mobile system. We apply also the 3 layer of the primary care and hospital response, so that the mild symptom patient can be treated at home, the moderate can be moved into the field hospital, and the severe critical go to the hospital. And human resource for health also being acquired from many different sectors, not only medical staff, but also from army, from volunteer, and other sector. And we try to ensure the access to essential health service. We provide a safe zone. We provide we assign the unsafe zone and outbreak area that restricts some of the travel. However, the telemedicine is increased recently that can help people from remote. And to protect the vulnerable people, we also provide the priority to vaccine, and also we have to free testing and free treatment for those who have health insurance, which is available for all poor people. And innovation and through the leapfrogging information and communication technology have also improved so far, not only for controlling the case, also controlling the travel, vaccine tracking, and also laboratory testing management. And I think so far what we learned from the public and private partnership is when we have a very good connection between the government and the private partnership, we can really have to improve the health support, and also to improve the country capacity of developing test kit and to prepare from ourselves that other things. There is some of the shortcoming and limitation and maybe a very experienced lesson to provide to others. We still have difficulty in some of the part of the pandemic response, and also for the curative and preventive connection. And some measures are still not close to reality because of the weak connection sometimes from the grassroots level and the higher level that still need the system to improve in the near future. So there is some of the experience lesson that we get so far, that the leadership and the direction of the leader is very important to bring the whole system to work to each other and to implement the early and the proactively consistently with the anti-endemic to measure that all of the activity of the health system. And the motto for on the spot is one of the very important things. And what we learned so far, we have to stick to reality and have a good communication, also mobilize strength for all people. And there is some of the lesson learned so far, and in the near future, if we have to deal with pandemic, we can continue this thing. We have a community COVID-19 team, which is the very, very small level, the lowest level that can connect the people, the patient, and the hospital. We have a model of the mobile medical station also that help to provide the medical at the primary. And the treatment treatment stratification according to the tower of 3 floors, I already mentioned before. And managing home treatment is for the infected people also very important, as well as a consulting support from distance. And other small things like a free ATM of rice, oxygen also can help in the future. So that's all for my presentation, and thank you for your listening.
Thank you very much, Dr. Tai, for that most informative presentation. And many thanks to both of our presenters for the engaging and thought-provoking thoughts. Now I'd like to welcome Caitlin Jizuyu, who will be moderating our panel discussion. Kate is a World Bank Group analyst for the Health, Nutrition, and Population Global Practice at the World Bank. She is a health economist by training and has been covering COVID-19 and vaccine-related health system strengthening projects for the bank. Kate, the mic is now yours.
Thank you, Kevin. Welcome, everyone. Good morning and good evening. Thank you for being with us today. We've had enriching presentations from Dr. Chennai and Dr. Tai, who provided leading guidance on their respective country experiences from Malaysia and Vietnam. In both case studies, we have learned that there are key ingredients for success and also effective preparedness and response, which includes strong leadership who swiftly acts upon responding to COVID in collaboration with different partners and key stakeholders. We also needed dedicated funding for the pandemic. We also have seen transparent communication to the public, that was important, and also robust human resources for health, just to name a few. All in all, as exemplified in the two presentations, we hope that this evidence-informed introspection will allow for a more thoughtful, efficient, and also comprehensive response to the COVID-19 and future pandemics. So now, let us turn to the panelists. Today, we have 3 distinguished panelists from Malaysia, Vietnam, and South Korea to reflect on the lessons learned on the preparedness and response to COVID-19 and what that means for future pandemics and epidemics. So to briefly introduce our panelists, so first, we have Dr. Helmi Zakaya. He is the CEO and the public health expert of Artificial Intelligence in Medical Epidemiology, AIM, in Malaysia. We also have Dr. Tu An Nguyen, the Country Director of Woodlock Institute of Medical Research in Vietnam. And last but not least, we have Chris Kang, the Director General of International Relations and Cooperation of NHIS, the National Health Insurance Service in South Korea. I also want to remind the live audience that the chat function on YouTube is now active, so please send any comments and any questions, and we will try to address them if time permits. So now, We will turn our attention to the panelists who will reflect on the challenges and lessons learned on COVID-19 preparedness and response in their respective countries. So first, we will start with you, Dr. Zakaya. Your expertise focuses on digital health and artificial intelligence in public health. So what has been the role and experience of digitization and artificial intelligence, AI, during this pandemic in Malaysia, and what are some lessons learned in the preparedness and response to COVID-19?
Right. Thanks, Kathleen, for the question. So back in 2017, I had the honor to work with circles of early proponents to apply AI in public health. Back then, it was for dengue surveillance, and the type of AI that we deployed was machine learning. It was for the specific purpose of dengue outbreak classification and prediction. That was an early era of data science, and we were testing the water. But then, as everyone here knows, like in Malaysia, back in March 2020, during the pandemic, we had to scale up fast, and we had to identify the use case for rapid application of data science and AI. So like what my colleague from Malaysia mentioned previously, in broad, we managed to deploy digital solution in 5 areas. First is to expedite contact tracing and monitoring of home quarantine patients. We also deploy digital solution to plan targeted community screening and verification of rapid test kit result at home. We use machine learning to re-stratify area to help us with a more targeted and nuanced lockdown. We use that to plan for vaccine deployment and status verification. And to some extent, we also use digital solution for resource planning in terms of hospital beds capacity. So I recall that we employed different techniques for various tasks. So we apply machine learning for area re-stratification. We use deep learning for vaccine verification. We do use neural language processing for home quarantine monitoring. These are all what we technologists term as narrow AI, given the fact that nowadays we start to see the emergence of a more sophisticated AI, like GPT-3. Those I think are still in its fancy as a use case for public health. Having said all of this, we do learn some humbling lessons from a failing and gaps across this region. I like to point out 3 in specifics. First being, I think our disease surveillance system is in dire need to be upgraded. I think we do have an infectious disease reporting system. It has been in place, but it was never scaled on par with the rate of booming population. So we have a legacy system. It was rigid in structure and architecture. It's very institution-centric, and it makes it very hard when we attempt to retrofit the system into a disease like COVID-19 that spread widely in community. The nature of how COVID-19 spread inherently will outpace the system design. And in many countries, we see that heavy investment is being made for hospital information system, but there are very little investment being made to digitize and strengthen public health and primary care system, which I think is the primary frontiers when it comes to a pandemic. A second lesson is that data is perennial. And when they are well collected, unfortunately, there's so much more to be done when it comes to visualization, analysis, and annotation. There is such a thing as data overloads. When that time comes, the expertise to utilize those data and to relay it in a comprehensive manner to all stakeholders are urgent. In this region, epidemiologists, data literacy, science communication experts are rather limited. So usually when data are collected, it is not well relayed. It can be remain in silo, or I think the worst case scenario is when it's misanalyzed and misrepresented. So these are opportunities where I think an AI solution can help. At the risk of oversimplification, I would say that machine learning helps us to find patterns in huge amount of data that otherwise would have been missed or had to be deciphered using a conventional statistical method. But that actually brings me to the third lesson. When we apply AI as a tool, just like any other tools in public health, I think it requires explainability. And this is the Achilles tendon of data science when it comes to applying it in health domain. So AI solution inherently, it has this black box nature, and it make it unsuitable to be applied in clinical and treatment settings for now. I, for one, as a medical practitioner, I would be hesitant to opt for one treatment modality over the other based on machine recommendation. But it doesn't mean that there is no place for AI in public health. So many actions in public health actually take place beyond the hospital wall. So if my audience are more observant, you can see the case in Malaysia. We apply AI solution to solve the problem of health resource allocation. These are high impact but low contestability area, and also can dramatically improve health delivery. And I think in summary, there's a bit of trade-off here when it comes to digital. There are some methods that are more immediate but not epidemiological. And then there are others that are more directly epidemiological, but at the same time, perhaps more out of date. Thank you.
Dr. Zakaya, for your insightful response. As you have mentioned, we hope to see more efficient and also better use of AI and digital health in the realm of infectious diseases and also public health in general. So now we will turn to Dr. Nguyen from Vietnam. So the question is, Vietnam has managed to keep the COVID-19 outbreak largely under control, similar to other two countries here. So what are some success ingredients in its response strategy to COVID-19? And could you kindly share some lessons learned from both successes and challenges faced in Vietnam? Over to you.
Thank you, Kathleen, for your question. I think that Dr. Phạm Quang Thái already presented very detailed about the experience of how Vietnam responds to the COVID pandemic over the last more than 2 years. And I could summarize in a few bullet points for the success of the Vietnam and neighbor countries on how they control this pandemic. So number one is all the decision has to be made based on evidence. And it has to be modified and adjusted quickly according to the access risk. And has to be deployed quickly to be faster than the virus. It is very, very difficult mission for any country to do this accurately and effectively. As we see over the response of more than 200 countries in the world, so challenging. For Vietnam, we are lucky that Vietnam has many epidemic or outbreaks of different infectious disease in the country. We have experience in successfully managing the SARS-1 in 2003 and H1N1 in 2009. And learning from that lesson, a coordination body that coordinate the response of different sectors in the country and at different level has been deployed in a very early stage, which help to make such decision to be deployed fast and widely in the country. And I also learned from our Malaysian colleagues that the digitalization plays a very important role in facilitating this decision to be deployed in the on the ground. We know that the decision is made, but if it's not deployed, then nothing happens. Number two is test, trace, and quarantine approach is important, particularly when we do not have a vaccine available. Vietnam is a developing country. We do have a lot of difficulty in accessing vaccine, particularly in 2020 and 2021. And test, trace, and quarantine of COVID, people who infected with SARS-CoV-2 and close contact has been done very rapidly and very effectively in Vietnam. That involves government officers, not only in health sectors, but also other sectors at all levels, as well as community participation that help to make it happen. Number three is lockdown. There is a lot of question about whether lockdown should be done and how it should be done. It's very difficult to answer without a good database system. So in Vietnam, we, as Dr. Phạm Quang Thái presented before, we changed from mass lockdown to targeted lockdown based on the risk assessment and based on the updated knowledge about the virus transmission to slow down the transmission and to wait for the vaccine to arrive. Number 4, and very important, not because step number 4 should step number 1, is mass communication on to provide the right information to the community as well as to all the system that responds to this pandemic. The information about preventive measures, about the vaccine has to be provided by different channels, not only by official communication channel of the government, but also by mass media, not only by doctor, but also by key opinion leader in the community, and using different tools, not only very short news, but also by a famous song that you may already listen, the song in Vietnam. Number 5 is vaccine strategy. It's very important when we do not have access to adequate vaccine. So how could we estimate or forecast the demand for the vaccine when the vaccine is not available widely for everyone in the country? Vietnam has identified prioritized population and arranged the vaccine program to target the prioritized population. And when vaccine is widely available, a rapid increase of vaccine coverage has been deployed and presented very detailed by our Vietnamese colleagues. It's very, very fast, and everyone can access vaccine even if they do not have any identity paper, or even the vulnerable group can access the vaccine. And number 6, the key success is community mobilization. It's very important. They participate in preventive measures. They contribute in resource for management of the pandemic, as well as support each other, because government cannot do everything for everyone in such a short time. However, we also have challenges. The scale of this pandemic is huge. It's too huge, more than anyone can plan or any resources could be allocated. In the future, we need to have a plan to address the kind of pandemic that go beyond our capacity. Finding the right balance between pandemic control measures and socio-economic activity and development is very difficult, particularly to address the demand of the community, people who do not know everything about COVID, which is reality. And particularly for the developing country, when vaccine is not available and when the sufficient data is not always be available at real time for assessment and decision making, and how to manage this procedure in a very short time is challenging. At least in Vietnam, data is collected but not collected timely. Not all data was collected, all data was not well managed and used. How to address that challenge is a big question for Vietnam, and the data is not only for the pandemic, but also for the hospital system. I believe that Dr. Wazari here already presented very clearly and very interested in your talk. The next challenge is coordination of the pandemic control in Vietnam. You can imagine that all the solution has to be agreed and implemented systematically and in coordinated way in 63 provinces, 600 districts, and 11,000 communes very quickly, accurately, in a short time, and last for many months. It's not easy. And I think the only way to do it is digitalization of the data and the procedure to provide quickly information, as well as communication to provide good information for everyone. The next challenge is hospital capacity to address with the big wave of the COVID pandemic. Even in Vietnam, in the Ho Chi Minh City, which has the highest resource for the hospital, we cannot address when the big outbreak of Delta happened in the city. And the last one, which I believe not only Vietnam, but other countries also have to deal with, is the booster dose. The community lose interest with the vaccine, and the second booster dose will be challenge for all the countries. So given all the success and challenge, I think that we need to be prepared better for the pandemic in the future.
Thank you, Dr. Nguyen, for sharing the experiences from Vietnam. And we hope that many countries could also learn from these valuable lessons that you shared today. So now we will turn to Dr. Kang, Chris Kang. Korea NHIS has been one of the leading health insurance agencies in the world, especially it has been further spotlighted on how it responded during COVID-19. So what are some lessons learned from NHIS perspective in its response to COVID-19 that could be shared with other countries? Over to you.
Thank you, Kate, for the warm introduction. Well, COVID-19 affected many aspects of society and life of the people. And not only NHIS, National Health Insurance Service of the Republic of Korea, the preparation, responses, resiliences for COVID-19, it's more like pan-government and all, the institutions included. So that, I want to share some of the lessons learned and important implications for future pandemic, not just for the NHI's perspective, but more the broader concepts of Korea. First thing, very important measure for the COVID-19 was Korea has national health insurance system, which means every citizen is covered by the insurance, and they were not afraid of having tests or having treatment from the hospital. That's because it's for free. 80% of covered by the national health insurance, about 20% by the local and central government. Compared to like US, for example, if you don't have a insurance, it's test and treatment needs more than $40,000. So the financial, the curfews and the limits, restrictions also impacts COVID-19 preparation and people's awareness as well. And second important thing I would like to stress is the law and ordinance support. I think in Vietnam and also Malaysia also mentioned the importance of law and ordinances. It's back to 2016 in Korea. At that time we had a MERS, Middle Eastern Repository Syndrome. And people are really kind of surprised of the pandemic. It was kind of coronavirus, things. So that, after the MERS, the situation and outbreak, Korea, constituted act we call MERS Act. That's, in even the situation in pandemic and very critical situation of a country, then personal information and any information can be used without, for instance, like seizure warrant. That's stipulated by the act. So that act is coming through onto the COVID-19 in 2020. So that, we were fully reversing the power of that act. We got the lesson from the MERS situation. And the also mentioned in the two countries' cases, ICT, digital transformation and data, it's very critical for preparing the COVID-19. More in Korea's case, after identifying the unconfirmed case, the process is like 5 steps, like patients monitoring, pathogen verification, epidemiological investigation, patients management, and contact tracing. Those are the 5 steps. And every step is reported and also monitored and shared for the all government agency, real-time basis almost. That's why, at the center of that, that ICT system and information protection is supporting the sharing of the very critical, it's a personal information, so that, it's shared for the government, and they're providing evidence-based policy as well as a protection the method and strategy based on data. So the data sharing and supportive infrastructure of the data, and also the power of ICT, that's like more like digital transformation. Capacity of a nation is a very, very important, especially the COVID, and it's proven in Korea's case as well. Another aspects, there are a number of things that I want to stress. It's a transparency of government regarding the COVID-19 situation, and that's also related to public trust. Back to was the outbreak of the COVID-19, Korean government started open to public the confirmed case, and also the case fatality ratio, and also there are a number of the key numbers open to public and very immediately, and also we are using SMS, short text messages to people that government, central government, local government, and they can inform the situation of the COVID-19 infection, as well as any kind of warning for citizen awareness. So that open, transparency, the government's transparency can increase the public trust of the government, the policy and the regulation. It's very cumbersome and very painful for everybody. However, the people were trusting government. That's because government is open to the situation without any disguise. So that that transparency and trust is also important for preparing the COVID-19 cases. And also, Korea also witnessed, this is also kind of the challenging things for Korea still, that we are finding the importance of public medical delivery system. The thing is, once the confirmed, then we were using the big data, so that if the less symptom or not serious, then he or she is mobilized to the regional care center. If there's a serious patient, and he or she mobilized to the negative pressurized room in the big hospital, which means if every confirmed case is mobilized to the big hospital, the medical system will collapse. That's why public medical delivery system has a really important, especially in the pandemic. Korea's situation is medical delivery system like 93%. It's more like private hospitals. So that we were it's the lessons learned from Korea as well, that now after the future pandemic we will strengthening our public health medical delivery system capacity. And other aspects, important thing is information protection and cybersecurity issues. The thing is, every information related to COVID-19 is personal information. Once the going outside, it's critical to one person, as well as it's a collapse of national assets. So that how we can guarantee the information protection onto the pandemic, that the shared data with some of the against the cybersecurity threats. That's really an important thing for us to provide some of the ICT support in the pandemic situation. Another thing I think this was not mentioned from the two countries' case, but it's a very critical thing, is the elderly care citizen, elderly citizen care for the pandemic situation. The thing is, elderly people are very weak for the pandemic, so that there should have very important measure or restriction or policy or any governance structure for helping the elderly citizen, especially for the pandemic, in terms of financial support, in terms of vaccination. Yeah, I get the Vietnam has the elderly citizen priority for vaccination. That's a really good measure. And more than that, how we can support, how we can identify the elderly people to protect themselves against the pandemic. That's a very important issue to prepare. And Finally, I want to stress the big data analysis importance. Big data. And ICT, support is strongly related to the big data, the utilization, and what data we should collect, how we can store the data, and how we can protect the data, and how much we can share the data. It's all about the data. And I think the future important, the pandemic strategy should be based on the data, which is evidence-based on the policy. That's also proven in Korea's case. Thank you.
Thank you, Dr. Kang. It's very encouraging to see how Korea's NHIS has not only achieved universal health coverage, but also has been very flexible and also adaptable in its response to the pandemic, either through the use of ICT, the big data that you have mentioned today, and also through the painful experience of MERS, where Korea went through in 2015. And I hope that there will be many key takeaways today that would be applied and replicated to other countries. So we will now ask the panel a series of questions to cover topics based on your submissions and also suggestions. Thank you very much for being part of this conversation. So the first question we have from the live audience is, so incredible progress has been made in a historic global vaccine rollout that is unprecedented in terms of speed, scale, and demographics reached. However, vaccine inequity has been a great challenge where vulnerable and marginalized lacked access to vaccine, especially in 2021. So what are the mechanisms of global governance of vaccine equity that could be implemented for the next foreseeable pandemic, and what can we do better? Perhaps Dr. Nguyen, would you like to start first, as you have a strong research focus on the realm of vaccine equity, and others could come in after?
Well, for the question, I think that first of all, we not only us, the panelists or people attend this webinar, but the whole world have to be agreed on the principle that vaccine has to be used based on the risk. And when I say the risk, it's the risk for people, not the risk for country, not the risk for economic development itself only, but the risk for people who may contract, who may be infected with the SARS-CoV-2, who may develop COVID-19. And we all know that people, the elderly, people with comorbidity, having high risk, and pregnant women as well having high risk for having the severe COVID-19 if they are infected with the SARS-CoV-2. And therefore, the vaccine has to be prioritized for those population. There is enough vaccine in the whole world for that population. However, vaccine allocation has not been allocated based on such principle as presented or as shared by David Wilson early in the webinar today. Even in Vietnam, for example, there is a period that there was huge discussion about whether people should be granted a green card to access service, to go everywhere if they are vaccinated. And you can imagine that when people have such privilege, then the vaccine won't be allocated to people who have resources, who have connection, who have ability to access the vaccine, but not always the people who have high risk of developing severe COVID. And unfortunately, in this pandemic, we learned that we can only control the pandemic, we can only return to new normal, we can only go back to our work and earn money if vulnerable people is protected, not the people who have more resources. In the world, there is the COVAX facility established very early during the pandemic period. However, we also observe that COVAX is not able to access adequate vaccine amount for all the country, the member country. Therefore, I think that in the future, we need to do several things. Number one is we need to develop a principle, a norm, a rules, a mechanism for vaccine distribution based on the risk, as well as mechanism and norms and rules to swap and share vaccine within the region between different countries. Number two is we need to have a digital platform we talk a lot about the importance of digitalization. And even today, we need a platform to share the information on demand of vaccine across different countries, different regions, and where the vaccine is spare. We need to have a digital platform to share knowledge, data, and technology to accelerate the innovation to develop vaccine. And number three is we need to have and adapt the policy to provide supportive environment for research and development of new vaccine, as well as vaccine manufacturing and importation in different countries. And talking about the developing country, in the future, developing countries should not rely on developed country and wait for the vaccine, but we need to build capacity for as many countries as possible to be able to manufacture the vaccine. We need to urgently establish a partnership for technology transfer and production, particularly for mRNA vaccine. We need to do a mapping of capacity and coordinate a full production line. Even if developing countries cannot produce or manufacture a vaccine by themselves, if they work together, they can develop a production line for vaccine manufacture. And lastly, in terms of procurement, we learned that a long-term public investment in vaccine procurement and technology development is important, and developing countries need to learn that about the granted procedure, procurement procedure through advanced purchase agreement and how to watch for vaccine with higher effectiveness, particularly now when WHO is coordinating a big technical working group to develop a pan-COVID vaccine. And also another issue we need to take into account is the pressure. We need to work together to have a pressure for reduction of vaccine price to be affordable for all countries and for people, vulnerable people in those developing countries to get a fair share of the vaccine globally. Thank you.
Thank you, Dr. Nguyen. Dr. Kang and Dr. Zakaya, would you have any insights on global governance and vaccine equity? Would you like to come in here?
Well, I think shortly I'd like to answer this also from the crossroad of vaccine inequity and digital platform. I think from the perspective of digital health, many countries decide to pack their vaccine distribution system to digital platform. It definitely is with the rollout, but I think it's a catch-22 situation. It can accentuate inequality for those digitally gapped or those marginalized because of policy decisions. So I think that's like fairly well spoken about. But I also witnessed the less mentioned just as the dire consequences. So there are marginalized communities unwilling to step forward to register digitally at the fear of persecution, thinking they can be traced back to their immigration status. So I think it's important in our decision to unlink between health policy and immigration policy when we had to apply health program through a digital platform. The other part of the equation is I think it will be useful for policymakers and program managers to frame digital solution not only as the health app in your phone. They are more than that, right? More importantly, we can go upstream. We can apply efficient digital solution for health asset management system in vaccine warehouse, transportation logistics, data mining to enable fair pricing in terms of public procurement. So these are all the pain points that can be improved with investment in machine learning tools. And I think it will facilitate the pipeline of those resources to the most needed, So I think when it comes to the issue of vaccine, we have utilized our advancement in biomedical science to rapidly come up with an effective vaccine. And I think now is a time and opportunity to employ another branch of science, data science, to make sure that those vaccines are not wasted and can be properly pipelined to those who need it.
Thank you, Dr. Zakaya. Dr. Kang, would you like to come in?
Sure. My short comments regarding the vaccine. There should have definitely a vaccine divide and inequalities among countries. But I will stress two things. The first thing is many important, the implications are also talked by the other panelists, so that in the pandemic, situation, we were suffered from wrong information, especially for YouTube, social medias. There are so much wrong information regarding vaccine, so that even the ordinary people can forcefully aware the vaccines, the effects, and so that they are against vaccine because of the wrong social media. So I'm not saying it's all the country, but so 100% of the false and incorrect information. But we should aware that importance of the social media for the vaccination, definitely against the wrong information. And vaccine, can be divided into like vaccine production, research and development, distribution, and investment. There are certain stages, important aspects of the vaccine, regarding vaccine. So then definitely the government should invest the vaccine for the future pandemic as well. And I would like to stress more on the foundation of the vaccine, the production. For instance, like for Pfizer vaccine, the cold chain was kind of required, the elements for distributing, mobilizing the vaccine. But some countries do not have those foundation, so the infrastructure like cold chain. So then, that foundation is critical for vaccine distribution. So government should invest not only the R&D of the vaccine itself, but also the foundation and infrastructure related to vaccine. It's also critical for the future pandemic. Those two things I want to stress. Thank you.
Thank you to the panelists for your insightful response. It is very clear that global coordination is urgently needed, not just from one organization or one country. Even COVAX was not enough, right? But it should be a collective effort for all high, middle, and low-income countries and leaders to achieve equitable access to vaccines so no one is left behind. So the second question from the YouTube live stream is from Thomas. So directed to Dr. Tai, but I'll direct the question to all panelists. So the question is, what are the three most painful experiences experienced due to COVID in 2021? Dr. Kang or Dr. Zakaya, would you like to start first?
Three most painful lessons. Okay, first, I think I can answer shortly that when the Ministry of Health and its agency engaged me for a consult in digital solution and for a consult in data analytics. I think the most painful lessons that I discover is that, like what Dr. Tai mentioned earlier, that there's just no data, and I'm not a magician, right? So as a data analyst, as a data scientist, I need my raw material, and the raw material being data. So the painful lesson is assuming that we have in place a data collection and disease surveillance system that was intact. And we learned it the hard way that what we had, what we used for dengue, what we used for tuberculosis, what we used for influenza surveillance system cannot be upscaled, and it was not on par at all in terms of in terms of COVID-19 rapid spread. The second and third question is it's very sobering experience to think that people who you think are tech savvy are not necessarily science literate. So this, like what my colleague from Korea mentioned, this is basically a perfect storm because these people have access, these people have unprecedented access to information, but unfortunately, the level of health literacy is not on par, and therefore they cannot differentiate between information and misinformation, and this can make the task of policymakers and program managers like ourselves be harder.
Thank you, Dr. Zakaya. I think due to time limit, perhaps Dr. Kang or Dr. Nguyen, if one of you could answer this question. and we can wrap up. Dr. Kang or Dr. Nguyen, any thoughts?
Just one, short. I know the time limits, so that I would like to talk about the more of the how we can, prepare for the elderly people. That's because we are living in this super aging society, and I got shocked that Korea is in year 2060. Still, Korea among the OECD countries, we are the oldest country, and the birth rate is the lowest, and the elderly people's labor, the percentage is the highest in the sector. So that how we can support elderly people, especially home care or institutional care, especially in pandemic, that should be covered, and we should have a very strong strategy, policy, ordinances, and regulation for like geriatric facilities, home care people, caregivers. Those are, I think, most important thing for elderly people, because we are living in all the countries are going, super aging society. Yeah, thank you.
Thank you. Thank you very much for this intriguing and informative discussion. I personally learned greatly, and I hope others did as well. So now I would like to welcome Jason Alford, the Special Representative and Country Manager of the World Bank Group Korea Office, to deliver the closing remarks. Jason, over to you.
Thank you, Kate. I'll be quick because I know we are stretched for time. So thank you to the speakers and panelists today, especially those of you who gave your experience of the COVID experience in Malaysia and Vietnam. That was very informative. And thank you also to Republic of Korea for supporting the research that we presented today. We heard a lot of important messages. We heard about the importance of preparing health systems, preparing health supplies, the importance of efficiency of vaccinations and other health interventions, the importance of digital solutions and data and digital surveillance to support policy, and the need to pay attention to equitable interventions into marginalised communities. And I think all of those very important messages are ones that other countries, other World Bank member countries, will be very interested to learn from the experience of Malaysia and Vietnam, and also the other countries that we've covered in this research. So thank you all once again. I look forward to our next webinar, which is on the experience of Fiji, as we continue this important piece of research. Thank you very much. Back to you, Kevin.
Thank you, Jason, and for that wrap-up. That was very great. Now, on behalf of the World Bank, I would like to express my sincere gratitude to all the speakers and participants who joined us today. Now, all the recordings for this webinar series will be available in the link shared in the YouTube chat box. You can also find a short feedback summary, and we would appreciate any comments or follow-up questions that you may have. We also look forward to seeing you again in the last webinar. We anticipate it will be later in the fall, and it will cover Fiji's experience and the global analysis conducted by the Seoul National University School of Public Health, which is the lead Korean agency for this project. Thank you again. Good night for those in DC, and have a great day for those in the EAP region. Thank you.